Hi guys, welcome back. So for today's video, we're gonna go over the examination of the nose, the mouth, and the neck. So for the examination of the nose, we start with inspection, as always. So for inspection of the nose, we start with just looking at the anterior and inferior surfaces of the patient's nose, looking for any deformities, any asymmetries, any visible obstruction. And then what we do is we inspect the inside of the, we test for obstruction. So what we do is we occlude each ala nasi in turn and ask the patient to breathe in through the unoccluded nostril, so just to test for obstruction. And then the third thing is we need to use an otoscope to visualize the inside of each nasal vestibule. So what we do is basically just tilt the patient's head back slightly. We push the tip of the nose and then we just shine the light from the otoscope to visualize each nasal passage. And then to get a deeper view, what we need to do is we need to grab the otoscope with the biggest speculum and carefully insert that in each nasal passage, being very careful not touching the sensitive nasal septum as we examine the nose. And the things that we look for are basically the color of the mucosa. So if the mucosa is red or appears red and swollen, then this points to viral rhinitis, sorry. And if it's pale or bluish in color, then this points towards more of like allergic rhinitis. And we look at the nasal septum. So normally the nasal septum shouldn't have any exudates, shouldn't be bleeding, shouldn't have any perforations. So nasal perforations is very common in people who abuse like nasal cocaine. Also, just in general, we need to make sure that each nasal passages are free from polyps or any abnormal growth or masses, as well as free from any foreign objects. After the inspection of the nasal passages using an otoscope, we move on to palpation. So basically, we palpate for the paranasal sinuses. So we have two. So we have the frontal sinuses and the maxillary sinuses. So the frontal sinuses can be felt just below the bony bit of the eyebrow. It can be here as well. And the maxillary sinus just over there. So that's it for palpation of the nose and the paranasal sinuses. We start again with inspection. So firstly, we inspect the lips. So obviously we wash our hands and we put gloves on before we touch the patient's lips, and we inspect for things like the outer surface of the lip, for any asymmetries, for any ulcerations, any nodules. We note the moisture of the lips, any cracking of the lips. And then after that, we inspect the oral mucosa. So ask the patient to open their mouth, and we can use a pen light or a torch to, shine a light in the oral mucosa. So just to help us visualize, the structures better. So for the oral mucosa, we note the color. Again, we note if there are any nodules, any ulcerations, things like that. So if there are white patches in the oral mucosa, then this indicates candidiasis. The third thing that we need to inspect for the mouth are the gums. So for the gums, we need to look for any bleeding, any like interdental papillae swelling, which may be indicative of gingivitis, as well as any ulcerations. And then after that, the fourth thing that we need to inspect are the teeth. So for the teeth, we basically note any missing tooth or teeth, any misshapen tooth or teeth, any abnormally positioned ones, any cavities, tooth decay, and we need to feel if there are any loose tooth or teeth, which may provide, which is it's like a risk for aspiration for the patient if they have like loose teeth. So we need to look for those. And then after that, we need the fifth one is the hard palate. So the hard palate is basically the roof of the mouth. Again, we need to ask the patient to open their mouth and maybe use like a torch or pen light to help us visualize it better, to provide good lighting. We look for things like the color of it, any abnormal ulcerations, any nodules, any lesions. After inspecting the hard palate, we move on to the inspection of the soft palate and the uvula. So the soft palate, we basically ask the patient to say ah, and we look at the soft palate and the uvula. So the tongue might actually obstruct the view of the soft palate and the uvula, so we can use a tongue depressor to push the tongue down to let us see the structures. So the soft palate should rise symmetrically and the uvula should stay in the midline. If the uvula fails to rise, like both sides fail to rise, then this indicates bilateral lesion in the cranial nerve 10 or the vagus nerve. If there's only like unilateral lesion in the vagus nerve or cranial nerve 10, the uvula would be pulled towards the normal side and the abnormal side will fail to rise, and the uvula would point towards, well, it would point away from the side of the lesion. Okay, so let me just repeat that. In case of unilateral cranial nerve 10 lesion, the uvula, which should be in the midline, will be pulled towards the normal side and will point, should be like that actually. So this is the tip of the uvula, and the soft palate is up here, right? So if there is a lesion in the cranial nerve 10 on this side, what will happen is the uvula will be pulled towards the normal side and it will point away from the side of the lesion. So this is the side of the lesion. So I hope that's clear. And then after the examination of the uvula and the soft palate, we look at the pharynx. So the posterior pharynx, again, when the patient says ah, the posterior pharynx, should move medially like a curtain. And then the last, I think this is number 8. Okay, the last and the number 8 thing, that structure that we inspect in the mouth, is the tongue. So we inspect the tongue when it's inside the mouth and ask the patient to stick it out as well. So we look for things like the color of the tongue, asymmetry, any atrophy, abnormal fasciculations. We make sure to inspect the underside of the tongue as well for any redness, swelling, any nodules, and any ulcerations. So when the patient sticks their tongue out, we need to check side-to-side movement if it's smooth. And we need to see if the tongue is pointing in the midline where it should point. If it doesn't, so if it's not symmetrical, it indicates lesion in cranial nerve 12, which is the hypoglossal nerve. So the tongue would, if there's a lesion in the hypoglossal nerve, the tongue would point towards the side of the lesion. Moving on to the neck, again, we need to start with inspection. So we inspect the neck for any asymmetries, any masses, any scars from previous surgery such as thyroidectomy, and any enlargement of the lymph nodes, so any visible lumps. Okay, and then we move on to palpation. So with palpation of the neck, we mainly focus on palpating the 10 lymph nodes of the head and neck area. So the 10 lymph nodes include the preauricular lymph nodes just in front of the tragus. So again, these are the preauricular lymph nodes just in front of each tragus. Okay, and then we have the posterior auricular lymph nodes, which are kind of like in the mastoid. You palpate it around that mastoid process area. And then we have the occipital lymph nodes just at the base of the skull, on both sides. And then moving down, we have the tonsillar lymph nodes around the angle of the mandible, again on both sides. And then we have the submandibular lymph nodes, which are between the angle of the mandible and the tip of the mandible. So they're here. And then we have the submental lymph nodes, which are located behind the tip of the mandible. And then we have the superficial cervical lymph nodes, deep cervical lymph nodes, and posterior cervical lymph nodes. And then we have the supraclavicular lymph nodes on both sides. With the palpation of the lymph nodes, we're noting the size of the lymph nodes, the shape, the consistency, if there are any nodules or if there are any tenderness. The enlargement of these lymph nodes especially the enlargement of the supraclavicular lymph node, especially on the left side, you need to suspect metastasis from thoracic or any abdominal malignancies. After the palpation of the 10 lymph nodes, we move on to examining specific structures in the neck. So we firstly do the trachea and then the thyroid gland. So for trachea, again, we start with inspection. So we just inspect if the trachea is still in the midline, which hopefully it should be. And then we palpate the space between the trachea and the sternocleidomastoid on each side, and the space between the trachea and the sternocleidomastoid should be equal on both sides. The reasons for tracheal deviation include like masses in the neck, also atelectasis or really large pneumothorax. Also, we can auscultate the trachea to hear breath sounds and any adventitious breath sounds like stridor. We can also auscultate the trachea to count the respiration rate. And last but not the least, we need to examine the thyroid gland. So we again start with inspection. So we ask the patient to like tilt their head back slightly and look at the area just below the cricoid cartilage, which is where the thyroid gland is. We look at this area for any asymmetries or any swelling. And then we can use tangential lighting to help us visualize the contours of the thyroid gland. So tangential lighting, so we can use like a pen light pointing downwards from like the patient's chin. And this would help us visualize the lower borders or edges of the thyroid gland. We can also observe the patient swallowing. So we ask them to take like a sip of water and then tilt their head back slightly and ask them to swallow the water, and observe for the thyroid gland moving up as the patient swallows. And for the palpation of the thyroid gland, firstly we need to stand in front of the patient and we need to identify and palpate certain landmarks. So we can look for the notched thyroid cartilage and the cricoid cartilage just below it. And then we go to the patient's, we go behind the patient and we put our fingers around their neck so that our index finger is just below the cricoid cartilage. And we just feel for the thyroid isthmus rise up as the patient swallows water. And we can also deviate. We can also kind of push the trachea to the right using the finger pads of our left hand. So I'm pushing it to the right, and then we feel for the right lobe of the thyroid gland with the finger pads of our right hand. And we note things like the shape, the size, its consistency, any nodules, any tenderness, and we do that exactly on the other side. If we feel any enlargement, what we can do is auscultate the lateral lobes using our stethoscope for any bruits of non-cardiac origin. And this is common in hyperthyroidism or thyrotoxicosis.